Welcome back to the Rehab Runway, and this episode is one that I'm really excited about. And one of the big motivations, actually, for me doing this podcast was an opportunity to speak to guests, and in fact, the guest that we have on today. He's a man that I've learnt an incredible lot from and continue to learn an incredible amount from. A man that inspired me to pursue my passion in treating runners, and it is the one and the only Tom Goom. Tom, welcome to the Rehab Runway.
Hi, Luke. Thank you so much for inviting me on. I've been really looking forward to talking to you about running and everything that surrounds it.
Excellent. And for those that have been living under a rock and don't know who you are, Tom, tell us a bit about yourself. You're known as the Running Physio, and I reckon I've been following your work for a very long time. And you used to write, you used to do a lot of, you've been doing blogs for a very long time now. Would it have been as early as 2013, 14? When did you start writing blogs? Yeah, early then. I remember, what was the saying that you had then? I run, then I eat pie. Was that one of your early sayings? That
That
was.
sounds right. That was my phrase. Yeah. So you're right. I think the first blog I did was about 2012.
Hmm.
Always been a runner. I used to run at school. Later as an adult, did half marathons and marathons. Got 10K coming up this weekend. So I've always had that passion for running, and then through physio, obviously started to work with more and more runners. And actually, I first got into treating running injury when I was working more in persistent pain, and I was finding actually a lot of the principles for working with people with like more persistent pain were like getting people back to activity, helping them up their understanding, etc., was actually working really well with the runners. But also, I was able to add in the other things I love, like strength and conditioning, like planning their rehab. So it really became the area I really most loved working with. And you'll know yourself. I know you're a runner, Luke, fair
Hmm.
deal quicker than me, I must say. But
Ah.
you know the sport, and that
Hmm.
makes such a difference when you're working with someone because you can really plan and problem solve and empathize when you know the sport, I think.
Absolutely. And what is it about runners that has drawn you to them, or that
Well,
they draw to you?
Well, I think it's that shared passion.
Hmm.
I think that the fact that I can, they can come into me and say, "No, I'm injured, I can't run," and it's having this big impact on my life, and I can understand that because it would be the same for me if I
Hmm.
couldn't run. Like it's a big part of my life. It's a big part of runners' lives as well. It really isn't just a sport. It can be a major coping mechanism for their mental well-being, can be their
Hmm.
social life. Like, so many things can revolve around it. So I think feeling quite quickly like you can connect with the patient on something, I think is really nice, really, really good. And then
Hmm.
you feel quite quickly you've got this shared goal. You both want to get them back to running. And so I think quite quickly you're on the same path together, which I like. And also, I think for all of us, we probably enjoy working with the people we think we can help the most. I don't know if
Hmm.
that's the same for you, Luke.
Yeah, yeah, absolutely. That's I think well, as I always say, it's an opportunity to talk running for most of the day, so my wife doesn't have to hear it. But
Yeah.
yes, you're right. It is you feel like you do have a lot to offer into that group. I 100% agree with that. And you've been doing this now for decades. You've been doing this for over 20 years. Am I correct? And how has your approach to runners changed over the decades?
Yeah,
How was a young Tom Goon practicing? I want to know what a young Tom was doing 20 years ago.
Wow, yeah. So a young me was, yeah. I think back to how little I knew at that point, and I feel I've learned a lot from there. But there's still so much to learn, isn't there? And that's another
Mm,
reason why it's so exciting what we do. Like it's constantly evolving. So I think I was probably back then. I was probably someone who focused just on maybe one thing, and sort of said, okay, this is why you've got an injury. And I think where I'm more experienced now, have a bit more knowledge, I think my assessment process is aiming to be a bit more complete.
mm,
So, it's looking at the training and load management, it's addressing their strength and conditioning needs, but it's also thinking about, sleep and recovery,
yeah.
nutrition, and thinking about like the drivers for training. Why is this person doing more than they can cope with? What's driving that? Are there psychosocial factors or external drivers? So I think
Mm.
that that's a big change. I really try now to get a complete picture when working with the runner. And I'm more systematic about how I approach the assessment to ensure I do that, because
What?
it's very,
Mm.
very easy. I think there's certain things that are very easy to miss unless you're in the habit of routinely asking about them.
Yeah.
Things like sleep, like energy
Mm.
availability, they're very easy things to maybe not get round to asking about. So you'll now systematically have them as part of that initial process. So I think it's a bigger picture and looking at the whole thing rather than, right, you're a bit wobbly on your single leg dip. That's why you're
Mm.
injured. Do you see what I mean?
Absolutely. And I mean, I love your analogy, and I use it all the time about the seesaw analogy of stress and capacity. Is that still something that you use to, an analogy that you use to explain to runners, or is there something you prefer to use differently these days? How are you explaining these things?
Yeah, I still very much use that. And I think that sort of load capacity balance, I think that's something that a lot of different people working just generally in rehab have kind of come up with simultaneously, because I've seen lots of other people, present that idea. I think Jill Cook did a nice paper in about 2014 on this concept of capacity. So I wouldn't claim ownership of that concept, but I think it's
Mm.
something we're all kind of thinking along similar lines. If someone's loading above what their body can cope with, if they're doing 10 miles and they're only ready for 5, something's going
Mm.
to hurt. But yeah, I
Yeah.
think a lot of us are on a similar page about that. And I usually combine that with the idea of the sweet spot,
Mm.
with runners discussing that kind of middle ground between doing too little and doing too much.
Yeah, and I think it's also it is an analogy that I think runners can understand, that if you're talking about, you've got, whether that be rocks or, things on this side, you've got poor sleep and nutritional issues there, and therefore you're not going to be able to have as much training stress before things go out of balance. So I think I use it, as I said, quite regularly, because I think that runners comprehend that, and they understand that things aren't just because of their shoes or that they haven't been stretching enough. And whilst we're on that, in terms of misconceptions, what are some of the misconceptions that you still see that runners well, let's start with runners first, that runners have about running injuries, and then we can go on to health professionals. So some of the misconceptions that runners have about their injuries. What are some of the common things that you see?
Yeah, so I still hear, oh, I think I got injured because I didn't stretch. So still a
Yeah.
lot of runners feel that the stretching's part of it, or they feel like, oh, I've got the wrong shoes, that's caused it. So there's still quite a lot of misconceptions out there, or they'll think it's because they're a hill striker or because they pronate a bit during running. So again, they tend to, because it's human nature, just blame that one factor,
Mm.
and then often they might want a solution that's based just around that. And then what we're hoping to do in the assessment is help them see, well, it's more of that balancing act as you're talking about between load and capacity, but also helping them to recognize that they can adjust that. They can strike that balance by dialing certain things up, like sleep and recovery, and dialing certain things down, like the amount of training they're doing or the intensity. So it's sort of trying to reshape things. And I think social media plays a role. I
Yeah.
know you're brilliant on social media, Luke, very active, but what I think we both see, there's so many one size fits all approaches on social media.
Mm.
So many things that start with all runners should forefoot strike is a
Yeah.
classic. And that shapes the opinions of runners. So they take on those things when we know it's a little bit more complicated than that.
Well, it is hard, isn't it? Because like you were saying before, it is complex, and these some of the content there is oversimplifying it and saying that this is the only thing that you need to think about, and that's yeah, obviously frustrating when you're dealing in the nuance of things, and there they are getting in their face that no, it's as simple as doing this, and obviously when they try and do that and things don't work, then they get frustrated, and so in terms of then, with the runners, and well, actually, how do if someone is under they've got such a strong opinion that, say, they come in and say, oh, my knee pain is because I've got flat feet, and what's your sort of common way that you might explain to that runner that, well, look, it's maybe related but it might not be. What's your sort of your way of correcting that, or
Yeah, that's a great question. I think that with so much of the stuff we do, there's a bit of a judgment needed.
mm,
And what I'd be wanting to try and pick up on when they're talking about that is how firm is this belief, and what will happen if I push back against it? Because if that's that first session with the runner and they don't know me well
mm,
yet, I've not really established trust, and the first thing I do is completely challenge their beliefs,
mm,
that can lead to a bit of friction.
yeah,
So I may not, if I feel like it's a very rigid belief, I may not choose to challenge it too hard in that first session. What I might want to do is come up with a slightly alternative explanation.
yep,
So, I've gone through your assessment and I pick out the positives as much as I can. So I might say, you've got really good alignment, you've got, good muscle strength in these areas, your balance is really good. What we found from the assessment is that your training's increased really quickly and your symptoms seem to come on after that. So I think that's probably the main reason your knees are painful, because that's put more stress on the knees and it's irritated them.
yep,
And then it might be that I might leave it at that. And then if I feel that flat foot belief is predominant, maybe a session or two down the line where I feel I've got a bit of trust, maybe they're seeing some improvement, we can start to drop that in and
yeah,
start to say, actually, looking at your alignment, I appreciate you have noticed your feet are a little flatter. I'd actually say they're very much within normal. And actually, what we see is that this variety in how we're all shaped is totally normal. And the amazing thing is, our bodies can adapt to these differences. I quite like little stories as well that can add to that. There's a runner called Fiona Oates, who has, I think, four or five different world records for marathon distances.
mm,
Incredible runner. She doesn't have a patella on one knee. She
wow,
had it removed surgically, I think, because she had a tumor, I think, as a teenager.
mm,
So that's quite a good example. Like, this is someone whose body is really different and
mm,
yet can set world records over marathon distances because the body's incredibly able to adapt.
mm.
So again, that might sow seeds that, okay, I'm a bit flat-footed, but actually in the grand scheme of things, it's normal. And actually there's people out there doing amazing things with really quite different bodies, if you see what I mean.
Yeah, yeah. I think what you said is very true about, we our job as health professionals is building that rapport early on. And I know I've been guilty of saying, things that were, I guess, violating the expectancy and their knowledge. It was just too much of a paradigm shift for them that they just, then they just shut down. So yeah, I think there's certain nuance to that, isn't there, of knowing when to talk and when not to, as you said, building that trust later on down the track. You've seen, obviously, been in now doing this for decades. There's been trends that have come and gone. What are some of the things, I guess, that you've seen over the years that you've let go of, the things that you once sort of held to be true? I know you mentioned before things being more simplified when you're early on, but as you've gone through, things that you've let go that you thought were once true. What's some of the things that you've
I think
changed?
the big one it would be things like static stretching. I think when I was newly qualified, of course, we'd be telling all the runners to stretch, stretch, stretch all the time
Mm,
because that was very much the sort of perceived wisdom at the time. So a lot of it would be about stretching and the importance of doing that pre-run, post-run. And now we see that there aren't as many benefits to that for runners. It's not perhaps as necessary as we think it is. And also I think a move away from blaming these alignment factors.
mm,
When I first qualified, I mean we're looking at 23 plus years ago now, it really was like, oh well, you've got slightly flat foot, that's why you've got pain. And it was often that single factor thinking of this is the issue. Whereas I think now we recognize that there's lots of wonderful variety in how people are shaped. And it doesn't seem to connect that consistently with injury. If we're looking at alignment factors like, pronation, leg length discrepancy, Q angle, they're not very good at predicting injury because they're probably just a variation of normal. So I think that's another area where my views have changed.
And with that stretching, so if a runner comes into you and says, "Oh, is expecting you to give them some stretches," what are you saying to that runner? It said, "Oh, Tom, my knee's a bit sore. Can you just show me a few stretches that might help with this?"
Yeah, I think I would probably want to know what they view as a stretch. Because the funny thing is, I think I don't know if you've encountered this, Luke, but sometimes any exercise you give to a runner, they can
Yes.
say, "Oh yeah, I was given a
Yes.
few stretches."
I know.
Yeah, I'm glad it's not just me that's encountered that.
No.
But then you look at what they've been given, and it's not stretch actually, but it's
No.
just they're labeling it as that. So I think again, you have that judgment of weighing up how much resistance you want to work with, like how strong their opinions are. If they do want to stretch, I just want to know why is it you feel you want to stretch for this?
Mm,
It's because my calf feels super
mm,
tight, and I just constantly feel like I want to stretch it out and I can't seem to get to that. So can you show me how to get to that? And then of course we can look into that. So tell me when your calf is feeling tight. Oh, it's nearly always after I've done my hill repeats. It's like that for a few days. Okay, right. So what we've
mm,
got is a calf that's tight because it's fatigued because you're doing a very high load activity for the calf. So A, that's normal, and B, let's have a little look at the intensity and duration of that session to see if that may be a little bit too much and what your recovery looks like afterwards.
mm,
I might say, okay, well, let's have a look at some stretches together in the session and see what feels like it helps you because they're not harmful.
mm.
We're not saying that they can't stretch.
Yeah.
If they help them symptomatically, great.
Yeah.
If I actually think, actually this is someone who's got a loss of range in the calf, it's not just fatigue. They
Mm,
actually are tight, perhaps on that side. I might talk to them about doing loading it in a lengthened
yeah.
position that is going to scratch that itch for the stretch as well. So I quite like doing a forward lean calf raise so you can
Yeah.
get them in a position where the calf feels like it's getting a bit of a stretch and load it up. So then we're kind of keeping the patient happy because we're ticking that stretch box, but we're also loading it and strengthening it in a stretch position, which would be what perhaps we might want as well.
And how often are you sort of getting them to do that and weights, how heavy are they going, usually instructing on that with that forward lean calf raise?
Yeah, so again, it's a judgment call.
Mm,
And this is one of the things I think people can find difficult. This is not always a straight answer. So it's a little bit about looking at the situation. Let's say we've got a runner that's really fatigued. You know that you think, right, this is a tight calf because it's got lots of training going on. And you're thinking, okay, let's add some strength work in. So you're already fatigued, and I'm going to ask you to do more. I'm not sure that's the best answer for that person. I
mm,
might be more inclined to say, can we have a recovery week and then retest you and see what your length is like, see what your calf capacity is like?
yeah.
Because if this is a fatigue issue, what we might want to do is do recovery. So in that situation, if we're doing the forward lean calf raise, I don't want it to be fatiguing. I probably don't want it to be heavy load. So I might even say, let's just do double leg, nice and easy, 3 sets of 12. We're not working to fatigue. It's a loosener.
Yeah.
Let's use that as a way of freeing up some movement. Let's say we've got the runner and we're looking at their schedule. They're not really fatigued. They haven't got a lot of stuff going on. They're just actually a bit tight and a bit weak. In that situation, I'm more likely to load them up. I might start them at around 12 rep max so they can
Yeah.
just about do 12 reps and perhaps do 3 sets and do that 2 or 3 times a week.
Yeah.
With the forward lean calf raise, your arms are out of action because they're against the wall. So I'd load them
Mm,
up with a backpack. So
yeah.
I think that is that challenge as well that we face is the judgment call. We know strength
Mm.
stuff's so beneficial, but it's judgment about how you use it, when you use it, etc. That's difficult.
And that's, I think you raise a really good point about the strength training, about knowing when to add that in, and I guess as an aside on that, are there certain situations where, and I know you're an advocate for strength training for runners, as am I, but are there certain situations when you'll say, look, now is not the right time to be doing some strength training, and if so, what are sort of examples of when you'd say now's not the best time?
Yeah, absolutely. So one is obviously when fatigue is the main issue.
Yeah,
So if you really through your assessment getting the idea that this is someone who's tired and tight, overtrained, and they really need to focus on recovery. Another would be when their symptoms are too irritable. We know there's so many benefits of heavy load, but if you've got someone hobbling down the corridor with highly irritable symptoms and you go straight to heavy load, you're really going to upset the symptoms and set them back. And another would be that it's not fitting with a race on the horizon. So
mm,
just, you've got someone seeing you a couple of weeks before a marathon, and they're in their taper period. Do you want to suddenly add in a fatiguing exercise program
Yeah.
that may irritate their symptoms 2 weeks out from a race? Probably not.
No.
So again, I do appreciate sometimes the answers to these questions have to end up being a little bit vague, but it has to be down to the judgment of like, with this person, what's my reasoning here?
Mm.
How is it going to work best for this person in front of me?
I had that exact same situation before one of our marathons just recently in Melbourne, a runner I saw 2 weeks before, and he said, "Oh, what can I be putting mine to strength training?" And I said, "Right now, nothing. Don't 2 weeks to go to the marathon. Let's not upset the apple cart, especially because there was already some niggles there. And so no, there is a time and there is a time not to be doing it. I had to chuckle before when you talked about patients and runners calling it stretches. If any of my runners are listening to this, please don't call them stretches. I've had it a number of times that they say, "Oh, those stretches that you gave me." I'm like, what stretch did I give you? So it's always, and that's again where people have said, "Oh, I was given stretches by so," and I'm saying, "All right, well, show me what they were," and yeah, a lot of the time they're actually strength exercises. So, and whilst we're on strength training and strength exercises, what are some of the common mistakes that you feel that runners and then also that health professionals are doing wrong with that? So starting with runners, what do you think runners are doing wrong with strength training?
Well, I think first of all, if a runner wants to do strength training, that's a real positive. So,
Mm,
I think that we want to highlight that to them if they're saying, "Oh, I'm doing some strength training." Highlight that it's a good choice to make, and maybe it needs some fine tuning sometimes. I think one thing is they tend to do too many exercises. So they may come in with this great extensive list
mm,
of different exercises that they're doing, and they're just irritating everything, or they're causing too much fatigue because they've got such a long list. And I think sometimes runners aren't necessarily that confident in loading them up enough. So I'd often suggest they do fewer exercises, but challenging themselves a bit more. Sometimes it's scheduling with runners as well. They're not necessarily sure when to put the exercises in. So they might do things like put them before a run, which can make it hard for them to run on tired legs. So often it's that like sort of fine tuning about how much they're doing and when they're doing it, how much they're loading. I think it's actually quite similar for clinicians, actually, funnily enough. I think
mm,
sometimes they give people too much to do, but they don't load them enough,
yeah.
so that they're not actually getting the benefits. And you also think, and this is probably human nature, sometimes people have a set of go-to exercises. These are my exercises I give runners, as opposed to this is what I think this person needs based on my assessment. So I
Mm.
think it's a little bit more about, specifics. Right, here are two or three really good exercises loaded at the appropriate level that address this person's needs and are planned carefully into their schedule, rather than a more like, this is my exercise sheet I give runners, if you see what I
Yeah.
mean.
Yeah. And what are, like, if you were to talk, generally, obviously not person specific, but some of the things that you think runners should include in their strength training. What are some of the exercises or key muscle groups that you think are important to target there?
So the key muscles for me, the ones that manage the most loads, as I know Luke, are going to be things like the calf complex, the
Yay.
quads,
Yeah.
yeah, glute med,
Yeah.
and the hamstrings. We know, I mean, they often are considered the big four. So what I would try and do is see, can we help someone have maybe three key exercises in there that are going to challenge at least some of those muscles, so that we're going to get some strength work in there. Some exercises are particularly good. I think things like a single leg squat. It's something that people can often do at home. You can, because it's single leg, it's often going to be challenging even body weight initially, but you can load it up to make it a little bit tougher. So that's quite a nice one for people to do. It's going to work the quads. It's going to work the glutes to some degree as well. I think a single leg calf raise really underrated, but again can be done at home off a step, can be loaded up quite easily, with a backpack, so really quite useful. Things like bridges and bridge variations can be quite good for working the hamstrings. Loads of different ways you can vary a bridge to make it challenging. You can put a slide out in it, like, as a way to make it more eccentrically biased. You can load it up, you can increase the range. So I think even just between those three, single leg squat, calf raise, bridge variations, you've got a lot of potential that you can get out of it. High level stuff, you've got things like single leg RDLs, really good for recruiting pretty much the whole glute complex, as you probably have seen from Collins et al.'s
Mm,
work. Going to work the hamstring eccentrically as well. So it's another good bang for your buck exercise. But yeah, typically I might get people to do three, and I'll often put it in a circuit.
yeah,
So if we're going to do, let's say we're doing single leg squat, bridge, calf raise, do the squats at a level where it's challenging for you to do 10 whilst those muscles are recovering. Do your single leg bridges, again
yeah.
challenging to do to get 10 done whilst those muscles are recovering. Do your calf raises, come back to the start and work through the circuit. And you can often find like a 15-minute circuit is going to achieve a lot for people, but it's quite time efficient.
Yeah, and if we were to look, and if I was to be a fly on the wall in Tom Groom's clinic room, what's your, do you have sort of a framework that you'll, in terms of history, then, examination or things that you'll try and cover? Do you how much time have you typically got with your on for an initial consultation with runners? How sort of your breakdown of your session? Obviously, it will look different from runner to runner, but as a general term.
Yeah, so I always used to have 45 minutes for initials and half an hour for follow-ups. But
Hmm.
recently I've nudged that initial assessment up to an hour because I've often felt like I want to have that little bit more time with it. I do have quite a structured assessment, and I've got a specific assessment sheet that I use for that because it allows me to make sure I'm covering the key things. So just really briefly on that, I tend to start with the history of present condition where I really want to hear the runner's story. So I'll say something like, tell me a little bit about this injury. How did it all start? And then I'll go quiet for as long as possible because as we know, that is really where they'll share a lot of the key stuff.
Mm,
And when I feel they've had a chance to share their story, then I'll start to get into the details a bit more about about the pain, about aggravating and easing factors, about our various clearing tests, 24-hour pattern, all the different things that we would usually ask. And so that's the sort of first part of the assessment. Get the story, really get to grips with their like pain presentation and behavior. And then the next piece I tend to go through is looking at past medical history. So asking if there is any relevant past medical history and delving into that a bit more. And then I've got my sort of standard screening thing. So I think do you have threads out in Australia?
yeah,
Thyroid,
yeah.
heart,
Ah,
etc.
yeah, yeah. Not that mnemonic though, but yes, yeah, yep, yep.
Yeah. What do you have over there? What do you use?
I actually use I tend to just go from head to toe. That's how I remember it. I just sort of go central nervous system, heart, lungs, digestive, genital urinary. So, but I have an intake form where they're ticking stuff off on there as well too. So I don't have a particular mnemonic, but I can't even remember what I was taught back at uni, which is bad. But
Yeah.
but but I think it is important as well, as you said,
It
to
is. I mean, we had threads, and I added what I use is called Dex threads, so DECS, and then the
yep,
standard threads.
yep.
So that includes a lot of things you're talking about. So the D is for digestion,
Yeah.
because we know like inflammatory conditions can
Mm,
affect the bowel, but also we know low energy availability affects digestion. So we ask about that. E is for eyes, because we can see iritis and things as part of inflammatory conditions that can present with tendon pain.
mm,
C is any past medical history of cancer. S is any skin changes. So things like psoriasis, again, can be linked into
mm,
to tendon pain. So it's sort of routinely having those questions in there. And then your threads are more standard, any thyroid issues, any previous heart problems, any history of rheumatoid arthritis, epilepsy, asthma, diabetes, or steroid use. So those are in there as just a standard screening process alongside asking, have you any other past medical history? We really just want to make sure we know the whole story.
mm,
Because I'm sure people listening in have encountered this. Like I remember it with a lady once, like, any relevant past medical history? No, no,
mm.
no, no, no. No injuries, no operations. No, 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 nothing that would be relevant. And then when we examined her legs, she had extensive scars on one leg. Oh yeah, I had a car accident.
Yeah.
How about femur pins?
Oh no, it
Like,
happens.
oh, okay, that might be relevant.
That
So
that.
that you want to screen for these things.
Mm,
But yeah, sorry, just continuing through the
mm,
assessment.
yeah.
Next, I tend to ask about energy levels.
Yeah.
So I ask this, what I call the battery test. If you were your
Mm.
phone battery, what charge would you be at the moment? And I've found that as a really nice question just to open up a bit of discussion around like how you're feeling at the moment, what your energy levels like. And if someone's coming back and saying, do you know what, I'm running pretty low, I'm at 30-40% at the moment. Why is that then? Why do you feel like that? What's happening at the moment? And that often will open up a conversation around, I'm really stressed at work, or I'm not sleeping very well, or my mind is full of all these things I'm worried about, that can then allow you to explore that more. And
Mm.
then just after that, as part of the structured assessment, I ask about mental well-being, I ask about sleep quality and quantity, and
Yeah.
I ask about diet. And we have a QR code in my form that the patient scans, which links them to something called PEAK,
Yeah.
Personal Energy Availability Questionnaire. And I routinely ask all runners to fill this out. It's by Dr. Nikki Keys, and it's a freely available online assessment that there's a male version and a female version that produces a report that I ask the patient to share with me. So that's been something I've changed recently, like make it part of the assessment. And that's just a little task I ask them to do after the session. Um, we routinely got that in there. And then I'm going through their weekly schedule. So
Yeah.
tell me about your training, what's going on Monday through to Friday, any recent changes in the training, any particular beliefs around injury. And then the final section is looking like social history, work and family life, so we're trying to get that, that's kind of the subjective assessment structure I usually follow.
Yep. And then actually whilst you're on that peak Q, that was, I just heard you on the another podcast talking about that, and checked it out, and it's very good. So I certainly recommend, we'll put a link to that as well. So do you fill that out in the consult room, or you send that to them afterwards to then email you the PDF results? Is that what you're usually doing?
Yeah,
Yeah.
so
Yeah.
I asked them to send it to me afterwards because
Yeah.
really the time that we've got with
Yeah.
patients is generally quite limited, isn't
Yeah.
it? And
Yeah.
so that's why we've got QR code. Actually, where I work at Body Rehab Studios, we've got QR codes in each clinic room.
Mm.
So with a little like laminated thing about why we ask the questions, and so it's very very easy for each of the clinicians to just routinely say to
Mm.
people, could you quickly scan this or take a photo of this so that you can scan it later, and just ask them to get into that pattern of routinely checking that energy availability.
Yeah.
And the other thing is, when you look at some of the questions in there, as you know, and it's been brought up on social media, some of those are really quite personal questions around sexual
Mm.
function and
Yeah.
libido. It's not always easy to ask those questions to
No.
someone in the very first session,
No.
especially when they don't appreciate that there's a context around it. There's a reason why you're asking those questions.
Yep.
So sometimes having the option of an anonymous questionnaire that allows them to do it separately, I think can be quite a nice other way of doing it.
Yeah.
So that you still get the key answers, but you don't necessarily have to have those tricky conversations the minute you meet someone, if you know what I mean.
Yeah, I agree. I think that's what another great thing about it too, and it's got a really nice breakdown in terms of the different categories of where they are scoring better, or where there may be attention there. Because I think, like, it is, as you said, it's hard for us to know as clinicians. Like, we're not sports dietitians, and I work regularly with them, as I know you do too. But we need to know, I guess, some things to look for to be able to triage them off to. We're not going to send every person we see to a sports dietitian, but certainly this is a step that helps us identify some of these runners that could need it.
Absolutely. And I think particularly we know, of course, the link between low energy availability
Mm.
and bone stress injuries. And I think you were saying beforehand there was a bit of a question around bone stress injuries from your followers, Luke, was
Yeah,
there?
there was one that was Tom. I didn't get the name right. Yes, it was Tom. Tom Varco asked about some subjective or objective tests that may lead you to suspect a bone stress injury. So yeah, certainly LEA is one. And whilst we're on that,
Yeah, definitely. So, and this can then link into your slightly systematic approach to this. So, in terms of subjective signs that might make me suspect bone stress injury, this is often going to be like pain that is located around the bone itself. So then, we're not having someone saying, oh, like it's the muscle or the tendon. Like, so it's often bony pain that is going to be aggravated by impact, sometimes by periods of longer weight bearing. So they might be on their feet. Perhaps sometimes a long day will trigger it. You often will see it more in your at-risk categories. So it might be those that have had previous bone stress injuries. They perhaps have low BMI, perhaps more common in female patients as well. And you may have other features that are more typical of your bone stress injuries, things like night pain, sometimes swelling. And in the superficial bone stress sites, you can often palpate and recreate their pain through bony palpation, but that would never be just on its own. It would be as part of that bigger picture of looking at the whole process.
Mm.
Also, part of it is the sort of ruling out the other pathologies as much as we can. It's not always easy to truly rule those out. But if your tests for things like joint, muscle, and tendon are coming back clear and aren't recreating their symptoms, that leans you more towards thinking bone stress injury. So
Mm.
if we've got someone with those features, let's say, for example, a femoral neck stress injury. So they're talking about pain with walking. It's pain in the hip. Maybe it's spreading down the thigh. Any impact bringing it on. They're getting some night symptoms. Often with these, if they're more severe, they might actually even be limping on it. Perhaps they've had a previous history of bone stress injury. What the systematic process I'm trying to engage in there is making sure we're assessing it properly and asking them to do that peak questionnaire so
Yeah.
that we can see if energy availability is part of it, and then making the appropriate referrals as the routine part of that process. So femoral neck is a high risk bone stress injury.
Mm.
We know that can progress to a true fractured neck of femur. So I want ideally really an urgent x-ray to rule out a true fracture. It won't rule out a stress fracture, but it rules out a fractured neck of femur. And really, we want an urgent MRI. So my pathway there is to refer to a sports physician that we work
Yeah.
with, who often work with Dr. James Noakes, very good. We'd
Yeah.
refer to a nutritionist with the peak score, and we're doing that systematically rather than as an afterthought. If you see what I mean, we're making
Yeah.
sure we're
Yeah.
doing that, and going down that route then with a sports physician, if they've got low energy availability, of doing a more formal and detailed screen for relative energy deficiency. So it's starting that pathway straight away as opposed to 6 months down the line, if that makes sense.
Yeah, and with you, you mentioned before, and just as a bit of an aside on imaging for bone stress injuries, in the UK, have you got quite a good direct access for MR, or is there often quite a wait? Is it expensive, or it is?
No, it's a very difficult area actually, where we are in the UK,
Mm.
because unfortunately, unless you're involved in sport,
Mm.
a lot of clinicians don't get the exposure to stress fractures and even high risk ones, and just not seeing them in the population that's coming through the door to see them.
Mm.
And what that means is that the knowledge isn't always there to recognize how quickly we do need to act on
Mm.
these high risk stress fractures. They're often non-weight bearing for 6 to 8 weeks.
Mm.
Some of them, like anterior tibia, you can be looking at
Yeah.
6 to 9 months away from the sport. They're really a
Mm.
serious deal. They need to be managed incredibly carefully.
Yeah.
But because it's in an athletic population who are fit and well as and able, they're not seen as a priority for a scan.
Yeah.
So yeah,
Wow.
it's a real challenging area. So some areas have got pathways for it, so that you can refer in and get quite quick imaging.
Mm.
What I tend to try and do is sort of work with the local services, communicate with them, tell them what my reasoning process is, what my concerns are, and see if we can get something quickly through, like the health service.
Mm.
If we can't, it sometimes we'll say to the runner, look, I know this is a cost, but I think this is an investment that you need to make in your body. And
Mm.
that's why I would quickly team up with the sports physician, so that you have that person to appraise the MRI findings, to guide on weight bearing, to actually do something with those results, if you see what I mean. So
Yeah.
I any of these complex bone stress injuries, I never manage on my own,
Yeah.
always with the right team.
Yeah, it's. I think we're quite fortunate in Australia that we do have direct access, and usually can get in within a few days to get that MR to get on top of things quite quickly. So I think, as you said, to avoid those high risks one dragging on, um, and you
Anything
just
I've
yeah.
missed there, Luke, that you'd think of with bone stress injuries? Anything you'd want to add to the mix there?
Um, I guess, nature of pain can sometimes be a pretty challenging one, can't it? Because they can often resemble other conditions. I mean, I think there's certainly, areas where, like, if a runner comes in complaining of mid thigh pain, I'm thinking straight away it's a femoral shaft bone stress injury, and I've seen a number of those being misdiagnosed as quad strain. So I think the location can be, leading to it. If they're pointing to their navicular, I'm panicking and sweating already. Front of the groin again, and pointing to the into the hip there. I think I do look back and I do wonder over the years how many I've missed. Like, I think I've become very much more sensitive to it now, but I do wonder, going back 15 years ago, how many of these that I might have missed, and they might have been lucky enough to, because I've never had anyone call me up and said, oh, by the way, my femoral neck snapped. I
Mm.
think they're lucky enough that maybe some that I've missed before have just then, just stopped doing stuff for a period of time and then been lucky for enough for it to settle down. But my radar is certainly up more than it ever has been, because I'm certainly seeing more of it. And I assume you're probably the same, but theories as to why, we talk about why this is happening more and more these days, like the incidence of bone stress injuries. What's your theory on why we're seeing more of them?
Yeah, do you know, honestly, I'm not sure. I think there's probably a lot that's happening around, like, both simultaneously overtraining and pushing far
Mm,
too hard and underfueling. I think
yeah.
I think there's probably stuff that bigger picture stuff that's driving that. And
Yep.
sometimes it can be around, like, the culture of sport, like go hard or go home, rest
Mm,
is rust,
yeah.
like that can drive people to these training behaviors, and who you're training with. If you're training with a group that embraces rest, recovery, fueling, sleep, taking care of yourself, and recognizes, like, do you know what, mate, you're doing quite a lot at the moment. How are you
Mm,
getting on with that? Versus, like, a training group that's push, 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 push until you break.
mm,
These things can take people beyond what they can cope with. There's a
yeah.
lot of stuff as well on social media that is misleading
Mm,
and pushes people to the wrong priorities.
yeah. Yep.
So I'm not a nutritionist or dietitian. And so I can't sort of speak about that in an expert way, but I am seeing stuff out there that's pushing people towards, like, high protein diets.
Mm,
My understanding is that, like, carbs are
yeah.
key.
Yep.
So again, do we end up with people perhaps focusing on the wrong types of nutrition
Mm,
as well as overtraining, perhaps? Yeah, I don't know.
yeah.
Like, a couple of theories at least.
I think the same. I think, again, it's interesting to seeing how the demographics of running has changed. Like, it's becoming so popular here. Like, you look at the number of applicants for London Marathon, and our marathons here that have never sold out before. And 20 years ago, our main marathon was struggling to get people to sign up, and now there's it's selling out in days. So it's yeah, a lot of people coming into running, and that then brings a lot of people into our door. But yeah, one of the things we've always got to be on the lookout for are these bone injuries. You mentioned before, going through that subjective assessment and then going on to your objective assessment. So what does that physical assessment look like? And obviously, again, condition specific, but things that you try and encompass within that part of your consult.
Yeah, good question. So I will, before anything else, have a look at a runner in standing. So ideally in shorts, so we can see the skin, the muscle tone, any swelling, anything like that. So I just want to have a little bit of look how they are in standing, so I can look at muscle bulk. I can look for any skin changes. As I said, any swelling, anything obvious, and just get a little bit of an idea of how that person is shaped. because it can have an influence on how they run. So, for example, I've got quite a varus limb structure. I'm someone, if I stand with my feet together, there'll always be a space between my knees. Just how I'm structured. So if you watch me run, particularly from behind, you'll see my feet will hug close to the midline, which makes it look like I've got a narrow stride width, but it's just how I'm shaped. So I do want to get an idea of how that person is built, if you see what I mean. I'm not necessarily going to blame that for their injury, but I just want to get an idea, right? Okay, this is how this person's structured. Then I'll start to go through the assessment process and look at some of the things I'm more likely to want to change. So I'll look at things like balance and control of movements. That might be looking at tests like single leg balance, single leg dip, maybe functional tasks that they've said are painful. If they're getting pain going downstairs, I may choose to look at how they're doing that. Then I want to go through and do the more kind of sort of diagnostic testing and the basic stuff. The stuff we'd all do. I want to look at range of movement. I
Hmm.
want to have a look around the joints above and below and just make sure there's nothing really key and obvious that I'm missing.
Yeah.
Do any diagnostic tests that might be relevant, and then I would typically go into my strength testing. So looking at the key muscles, most runners at some point we're going to look at those big four we talked about, calf, quads, glute med, hamstring, and anything that's relevant to them.
Yeah.
So if foot and ankle, we might look at testing around the foot and ankle.
Yeah.
And then going on from there, it might be looking at impact if I think that it's safe to do that, and
Hmm.
they're non-irritable.
Yep.
There are times where it's not. That patient that's hobbling in with a suspected high risk bone stress injury, we don't need to get them jumping about.
Yeah.
We have to, everything we do has to be risk assessed in terms of that way. And I always point that out because I have had runners with suspected high risk stress fractures hopping on them, like they've hopped on it themselves. They said, oh, I tried hopping at home. And I'm like, no, let's
Yes,
not do
listeners,
that. You don't.
listeners do not. Is that we'll put a disclaimer on this podcast. If don't hop unless instructed.
Exactly. So to be clear, these are runners that have told me they've
Yeah,
hopped at home, not
yeah, no,
I've
no,
told them
no,
to hop.
no, no.
Yeah. So they've told me I've tried hopping on it, and I've said no,
Yeah,
no, because
yeah,
it's not. You're totally right. If you suspect a high risk bone stress injury and they've got pain with walking, you don't need to test
no,
impact. So yeah, everything we do, we have to be careful about whether it's safe for the individual. And as you say, very important for your listeners, be guided by your health
yeah,
professional, not
yeah,
YouTube.
no,
Um, so, but what I might be doing if it is safe to do impact with those people is looking to see if they can do it without symptoms. So simple things like jogging on the spot first. So we do light impact first because we're looking to see can they tolerate the impact of running.
yeah,
Because if you can't jog on the spot for a minute without getting your pain, it's unlikely you're going to tolerate much in terms of running. So that
yeah.
would probably be the bulk of the assessment. But as I said, tweaked depending on the patient, their presentation, what's safe for them, etc.
And then we did have a question sort of leading into this. Then from Alex asks about how important is gait analysis for in your where does that what role does that play in your assessment for a runner?
Yeah, it's another really good question. So I don't typically assess running gait in session one.
Mhm.
I would usually do it in around about session 3 or 4. So roughly how things plan out with my runners is session one. What I want them to go away with is a good understanding of the injury. What is it? How has it come about? How can they manage it? And usually, as part of that, there'll be some management advice around bringing their training to a comfortable level and maybe a couple of exercises. So that's what I want them to go away with. Session two is often about tweaking. Like, have we got your running at a level you can cope with at the moment? Do we need to dial it back a bit, or are you ready to do a bit more? And the same with the rehab. Can we add a bit more to this now, or is it a bit provocative? Do we need to dial it back? So often those first couple of sessions are about getting the load management and the rehab at the right level. Now, once that's at the right level, they need some time with it. So that might be in session 3, we say, okay, like keep going with your rehab. You know how to progress it. Keep going with your running. We've got a plan in terms of how to progress that. Let's look at how you're running. And then we'll have a look at that. And what we're looking to see is if there anything they're doing with their running that's putting more stress on the area that's sensitive and sore. If there isn't, we wouldn't tend to change it.
Yeah.
But if there is, we might look to make a subtle change to it.
Mm,
Because one of the downsides with gait retraining is you can't eliminate load, you're going to
mm,
move it somewhere else. So, the most classic example is increasing step rate by as little as 5%. it's a small change to reduce the stress on the sensitive tissues. So I do think it can have a role, coming back to Alex's question. But I do think it's probably a smaller role, and it comes under that broad heading of load management,
Yeah, yeah.
really. What we're doing is reducing the load per step. But I would argue you can get people better without changing their gait with the more broader load management strategy, which is modifying the training rather than load per step.
And that of the leading into that, then talking about load management, what are some of the the common misconceptions that clinicians have around load management?
Well, one of the things that surprised me, I'd be really interested in your view on this, is some clinicians won't necessarily engage with changing a runner's training.
Yes.
So I had somebody on one of my courses recently said, "Well, I'm not a runner or a coach, so I can't be changing
Mm,
their training."
yes.
And my thought is that if you're modifying their training as part of managing their injury, then I feel that really falls under our role. It's load
Hmm.
management. Um, if you're trying to do it for enhancing performance, it becomes a little bit more of a grey area, and that's where I would work with a running coach. But
Yeah.
I actually do think as clinicians, we do need to modify the training. And if we don't feel able to do that, if we don't feel that we have the knowledge, then we need to team up with someone
Yeah.
who can. Well, what do you think on that, Luke? Do you think
Uh,
it's
I
part of our role?
I do 100% agree with that. I think that it does much like and again, I think that there needs to come a basic understanding of a sport, and that's where again, I work with different sports that I have no idea about, but asking them about what they're doing, and then use your clinical reasoning. Is does that sound reasonable? Or I like your run tolerance testing. Like if they're doing something and it's sore, well then what point can you get to without it going above that point, and then starting below that. So I think that's really important, and at its basic sense, that is well within our role. I mean, I always love if someone does have a coach that we can work with them, but unfortunately the vast majority of runners do not have coaches, and that's probably what leads them to making training load errors and coming into our rooms. And I mean that's where I found myself, and I've been doing more coaching over the last 5 or 7 years now, and I sort of found myself naturally drifting into that space, and actually really enjoying it. So I do coach a lot of my runners, and do so I've got that knowledge to do that, and I do often get clinicians asking me, it's like, oh well, where do you learn this? What do you do around this space? And I think that they also realize that it is becoming important. But like you said, just asking them, like, tell me your Monday to Sunday, what you mentioned before, getting a look at their Strava profile, their Strava bars, and seeing what they're doing. It is definitely within our scope, because you could be doing all the best, assessment and exam, but you're sending them out there and they're just going and making the same mistake again. They're going to be back in there, or they're not going to get the improvement, are they?
No, no. So
Mm,
I think that's one of the first things for clinicians is recognize that it can be part of our role, but also recognize where your competence sort of starts and finishes, and seek help if you need it. Like, don't feel
mm,
I'm not expecting clinicians to sit down with a runner and plan a 16-week marathon training program session one.
yeah,
So,
yeah,
but
no,
I kind of see it a little bit like are objective tests that we do. Each
mm,
run is like an objective test. So the more specific we are about that run, the more useful the information is. So if, for example, we want a runner to find out what a runner can cope with in terms of distance. We've got a reasonable idea that from their subjective that maybe they can manage 5K. We might say, if we think it's safe to do so, could you do a 5K run, but can you do it at your easy pace? And perhaps you've talked to them about what that is. Maybe it's 6 minutes per K or something like that. And just stop at 5K and let me know how that was afterwards. So we can be really specific about, okay, we've done 5K run at 6 minutes per K. How were the symptoms? And then that allows us to choose what we dial up. Now, for that runner, let's say their goal is to get to 10K. We might say, let's stick with 6 minutes per K. You can do 5K. Let's start to just dial the distance up and keep the intensity the same. So, I think there's a lot that we can do around exploring what's manageable,
mm,
and sometimes as well remembering that load management isn't always about doing less.
no, Yeah.
it's sometimes about doing more.
Mm.
So it's quite a nuanced sort of area. So I was chatting to a guy the other day, for example, who I just met at a social function actually. Again, all of us have been there. That kind of, what do
Mm.
you do? Oh, I'm a
Yeah.
physio. Oh, I've got an injury.
Oh, I've got this sore knee. Yeah.
Yeah, exactly. So he had ankle pain, and what he was doing is running once a week, about 10K,
Mm.
taking 4 or 5 days to recover, and then running again.
Yeah.
So we had a bit of a chat about it, and I said, obviously, I can't assess you, I can't really advise you here, but have you thought about maybe doing more frequent runs, but at a shorter distance?
Mm.
Chatting to him, it sounded like about 4 or 5K was very manageable. Have you thought about trying to do maybe a couple of runs at 4K and see how your body copes with that? And if that's going well, maybe doing a couple, 3 runs a week at 4K. So you actually, rather than doing 10K in a hit, you're doing a little bit more, but spreading it out over the week. So it isn't always about doing less. A
Yeah.
lot of it is about that, looking at what they're doing, reasoning through, communicating with them, and actually having a good old delve into what they're doing. I was doing that with a runner this week because he was a bit frustrated that he wasn't progressing, and I could hear subjectively what was happening. His symptoms were settling, and then he was stirring them up with speed work, and then they were settling, and he was stirring them up with speed work. So we looked at his Strava schedule. We went through run by run. How was this run for you? Trying to establish which ones were aggravating, and it became quite clear that any runs above roughly 8 minutes 30 per mile were provocative.
Mm.
Any runs slower than that were not.
Mm.
So, but that took us sitting there for a good 10, 15 minutes,
Yeah.
going through Strava stuff, talking about the symptoms, and then we established, okay, well, look, let's keep the volume in there because you're coping with that, but let's make sure that you're not going above the speed that you can cope with.
Mm.
And to help you with that, set up an alert on your GPS watch where it'll buzz at you if you're going above your target pace and
Mm.
remind you to slow down. So that can be all part of that load management strategy. It's problem solving,
Mm.
I think.
And that's again, it's just so important to do because you look in that instance there. If you hadn't done that, you probably that guy would have just left and said, "Oh, that's not going to work. I don't know what the answer is." So doing your due diligence and the time looking at that stuff is so important, isn't it? And I know you were talking about doing more of a thing, but a favorite saying I've got from Tim Gabbard is it's not the load that breaks you, it's the load that you're unprepared for. So, and I know you've spoken to Tim and had read a lot of his stuff. So,
Yes,
yeah, it's educating that they need
that's a
to
good
building it
phrase.
up.
Yeah,
Yeah,
I also
it's
I also like, and I know I've shared this one before, but I also like a running injury is like a hangover.
mm,
Usually caused by too much too quickly, and then as soon as you feel better, you do
yes,
it again. Then
yes,
there is an
that's
element
right.
of that, isn't there, with our runners, and that's why we often want to explore it. Why are we doing this again? What's
Yeah.
what's the pattern here that we can try and break down? But the other thing is trying to think as flexibly as you can with load management.
Mm,
So trying to look at how do we make progress. So that might be some things like thinking about, can we just focus on progression of one area? So you talked about strength earlier. Another time where I may not choose to progress strength is if someone's struggling to progress strength and running together. So we might say, let's stabilize your strength exercises at a level we know you can cope with. They're not irritating your symptoms. We'll keep that ticking along. That will maintain the strength you've got. And now we're going to focus during that period of increasing the running towards where your goal is. So you're not navigating doing two things at once.
yeah.
Also having a plateau. Now, runners see a plateau as a negative thing, but it can be really positive. So let's say you've got a runner who's got up to 5K, and anytime they push above it, it just irritates something. We might say, okay, well, let's stabilize you at 5K. Let's plateau that training for maybe even 4 weeks. Get your body used to it. Maybe if you can tolerate it, we'll nudge the strength stuff up to get you a bit stronger. But let's get your body really used to 5K, stabilize your training for a few weeks, and then push on. So it's,
Yeah.
it's, it's a lot of like tweaking, adjusting, problem solving. Where can
Mm,
we progress? Where do we need to hold things still?
mm,
And there's an art to that as much as there
yeah.
is a science, I would say.
Yeah, absolutely. That was a talk I did recently on the weekend, and I was saying exactly that. There's an art and a science, and so we've spoken about some of the rules that you can use, but sometimes it is trial and error, and it's the person in front of you and what they need to do and their goals and everything else involved in that, isn't it? So it does take some experience, but you certainly you've got to start somewhere. So, and some of the things that you've just mentioned are really a really important place to start. Some of the things that you've what are some of the things that you've made a change to in your assessment that's made a really that's made a great impact? So something recently that you've either taken out or you've swapped in. What's something you've changed recently?
Well, as we touched upon, I think bringing in the peak has been
Mm,
a real benefit. I think is having it as a standard part of the assessment, and also the battery test. These are two things I brought in relatively recently, and they're both, asking people about what charge they're at in terms of battery. They've both been really useful to pick out different things. More broadly, if we're thinking about changes over time, I would say now, compared to when I was a new clinician, I'm much more thorough in how we test strength. I'm more specific about what I consider to be challenging tests and being prepared to progress on through those tests when it's safe and appropriate to do so. So a bit like we said earlier, it wouldn't be safe and appropriate to get someone doing impact if they've got a risk of high risk stress injury. We can't be loading people up really heavy if their
mm,
symptoms are highly irritable. But when they're ready to, we do need to challenge them. So I think that's been a big change. And another small practical thing is I don't now are like write out great big exercise programs for people after sessions. I get I get them to bring their phone and we video them doing the exercises in the session and I
yeah.
talk through all the instructions. And that's a small change that saved me a huge amount of time and
Mm.
means they've got everything they need just there ready to go on their phone.
Yeah, I like that too. Actually, I say, give me your phone. There we go. Let's go and run through this. And yeah, then they've got that there for reference, so that they don't come back and doing something totally different to what you've shown them, which
Yeah,
still can sometimes
exactly.
happen. But
And there's a
um,
little way to do that as well with if people are doing online assessments.
mm,
So, because when I do online sessions with people, I use my phone as a second camera, and you can connect it up to whichever platform you're
mm,
using to host it. So I use my phone as a second camera and I demonstrate the exercises and I actually just hit the record button on the video so that as I'm going through their exercises within that session,
mm,
I got it recorded and then I can send them a link to it afterwards. So
yeah,
if people
okay.
are listening in and you're doing online sessions and you want to save a little bit of time, that can be worth having a little look at, see if that works within your own personal setup.
Yeah, that's a great tip. Um, we bring it home because I am mindful of time. But if we sort of go towards we've touched on a little bit about the return to run progression. But in terms of, I guess, is our runner ready to return to run? What are some of the things that you're considering about? Yep, they're good to go now. Whether that be subjective or objective things that we're looking at.
Yeah, so obviously this is specific to the patient and their pathology.
Yeah, of course. Yeah.
And a big part of this process and everything we do, assessment, treatment, return to running, is that managing risk versus reward.
Mm,
So we want to make sure that we're minimizing the risk and maximizing the reward with everything that we do. So the pathology will play a big part. If you've got someone coming back after a high risk bone stress injury or a prolonged time away from their sport, maybe they've had surgery, ACL reconstruction, something like that, we're going to be much, much more thorough in their readiness to run testing than someone that's had a couple of weeks out because of minor muscular pain. So I think we this process needs to be adapted to the individual so that our testing is right for that person. So from a pathology point of view, we want to know that they're appropriate stage of healing. For our high risk bone stress injuries, that may also include having MRI evidence of sufficient healing. We may, with some of these, look at making sure they've got enough energy availability first, particularly
mm,
with bone stress injuries. So we'll make sure that screen is done. What we want is minimal day to day pain. Ideally, with bone stress injuries, no pain day to day, so that they can walk half an hour pain free. They can do all their daily tasks without pain. This is establishing that they're not irritable. Because if you're just getting pain just walking up and down the stairs or doing the school run with the kids, you're probably less likely to cope with running. So a lot of this process is seeing, have they at the right stage of healing? Are they no longer irritable? If that's the case, then we can start to look at more specific tests. So can they walk half an hour pain free?
Yep.
Can they manage jogging on the spot for a minute pain free? So we can see they can cope with impact. So those are some of the key parts of it. As I said, with the more complex ones, we might be very diligent about them meeting their strength and conditioning needs. So we might set specific goals in terms of strength needs to be met. We may be more diligent with their impact tolerance, including going through that progression of impact and making sure it's pain free. So jogging on the spot, squat jumps, bounds, all the way through up to hopping, but when it's safe and appropriate to do those tests. So I'm hoping I'm not confusing things too much, but it is that process really of thinking for this individual and their pathology, are they showing me that they're ready to meet the demands of their sport?
Mm.
And if you feel they are, the final kind of piece in the puzzle is often a test run. I usually start a test run at easy pace of about 3 minutes and ask them to report back to me the next day.
Yep.
So, runners, you say do 3 minutes, and if they're pain free, they'll go and do 3K, won't they? So
Yeah, that's
I will
right.
say, even if you feel like you're top of the world, no pain, I want you to stop at 3K because we don't know what the delayed response will be. So once we know that they can cope with that, we can then start to think, okay, you're passing all the tests subjectively and objectively. Let's think, plan a return for you.
And in terms of pain, what are rules that you're setting around pain on that process? So, are you wanting pain free? Are you allowing pain? What are your guidelines you're telling your runners?
So with bone stress injuries, I do want pain free.
Mm.
You'll know from Warden O'Toole's work and others that bone stress injuries do not do well loading into pain.
Yeah.
And I apply that both to assessment, rehab, and return to running. We want to keep them pain free. So in that group, we're looking at finding a pain-free level of loading throughout, both during and after. So during the run and after in terms of their pain. For most more sort of soft tissue based injuries, like say tendinopathy, we might be more accepting, I would say, up to about a 3 out of 10 pain, as long as it settles quickly. So it's back to kind of baseline levels by the next day. But
Hmm.
again, there's a little bit of a judgment call because although we might accept that, we don't really want that, do we? We don't want them to be in pain.
Mm.
So if they've not got an event coming up, I have a phrase: no race, no rush.
Mm.
If you're not rushing to get back for an event, why not go a little bit slower with that return to run process and keep it fairly comfortable?
Yeah.
So
Yeah.
if we
That's
can find a nice, easy, manageable level and use the time you've got.
And that comes back to that risk reward, doesn't it? So if there's no need to take risks, then why not slow things down? I like that.
Absolutely. And then in your reward, you've got some really low hanging fruit.
Mm.
Sleep, no risk,
Yeah.
super high reward. No one's
Yeah.
injured themselves having a sleep, as far as I know.
No, unless they're sleepwalking
Nutrition,
or something. So,
nutrition, no, yeah, that's true. Nutrition, zero risk, high reward.
yeah.
Cross training's another one. It's low risk. It's not no risk because if you've got
Mm.
someone who's energy deficient and doing too much
Yeah.
cross training, but again, generally it's low risk, high reward. So there's lots of different ways we can help that risk reward balance as
Yeah.
well. So top up their training with some cross training if necessary.
And so we better head towards the finale, but what's sort of exciting you about the future? Where do you see our role and exciting things that are coming? What does a crystal ball say for Tom in the future of running rehab?
Oh, what a great question. Well, I mean, I'm excited by the fact that more and more people are running. I think that's
Mm.
amazing,
Mm.
and I think we're well positioned to really help them, A, return back to the sport that they love and B, hopefully keep them, doing that sport. I like to watch the local marathons in each year because I'll see people I've seen years before. And if they're out there still doing their marathons, I think, yeah, we've succeeded there. That's a good thing. And I
Mm.
think in the future, there's probably hopefully going to be a little bit of help from the tech, and we're starting to see this
Mm.
already. When I first started out with runners, they might have a notebook where they'd keep the training data, or an organized person might even have the spreadsheet. Now it's all mapped out on Strava,
Yeah.
or Garmin Connect, or Training Peaks, Trainers One, any of the training sort of softwares they've got. So I think there's some potential to be able to use those with people,
Mm.
so that we can help plan their training. And then the final thing, what I'd really like is more connected work between the health professionals, because I really try and work with other team members, like I said, running coaches, strength and conditioning coaches, sports physicians, podiatrists, nutritionists, because
Mm.
I think the patient gets the best standard of care. But it can be people all working individually and never really communicating. And I really hope that's something that changes in the future and we're teaming up a bit more.
Yeah, I certainly see that is changing. The breaking down of silos and people working with each other, and as you said, forming a team around that runner, and people recognizing that they can't possibly know everything about everything. So getting other people involved for their strengths, to add to the progress. And so
Absolutely.
if we were to finish off with some fast fire questions now, so because we have been very generous with your time, but 3 tips for runners, firstly, on their running recovery. What would be your top 3 tips for runners, regardless of injury? What would you say? I think we've touched
Okay.
on a few already, but yeah.
So, first one, I would encourage runners to plan their recovery as carefully as they plan their training. So instead of seeing recovery as something that just happens when you're not running, it's sitting down and thinking, okay, if I think about my training week here, maybe even my work week and what's going on with my life at the moment, when's it going to be a really good day for me to actually focus on my recovery? Maybe it's going to be the day before your longest run, so you're nice and fresh, or the day after if that's when you feel the effects of that long run. And planning into their recovery weeks as well. Actually planning in typically every fourth week to do a bit less to give your body a chance to recover. So I think that's tip one, plan it.
Yeah.
Tip two is actually make sleep a priority. And I know
Hmm.
this is a bit of a buzz term. What does that actually look like? Well, what it looks like is when it's getting to your kind of bedtime,
Mm.
and the time you need to go to sleep to actually get the hours you need, it's actually going to bed. It's not
Yeah.
playing on
Yep.
your phone
Scrolling on your
or one more
phone.
episode of your program that you want to watch.
Yep.
It's actually, yeah, making it a priority, because it's our best form of recovery.
Mm.
And that means sometimes not sacrificing it to train more.
Yeah.
Planning your training so you don't have to. I work with runners that got up at 3 a.m. to run,
Oh, brutal, isn't
and
it?
it's
Yeah.
it's remembering that our training process is the stress of training plus the recovery leads
Mm.
to the changes. If you've got the stress of the training without the recovery, you just get fatigue. You're not going to get the
Yeah.
benefit of those sessions.
Mm.
um, and then the third point would be really give your nutrition and energy some thought.
Yeah. Yeah.
Look into something like the peak, because I think for most runners, when they're under fueling, it's not a deliberate choice. It's an accidental effect of the
Yeah.
fact that they haven't really considered what their needs are.
Mm.
So doing that assessment can help you know where your level is at, and then really plan the nutrition again as part of this. So nutritionists we've worked with have talked about having a fueling routine. So particularly if you're doing a long run, fuel beforehand, maybe even fuel during, fuel afterwards, so
Yeah.
that it's part of the process, for your body.
And then going on to health professionals. So, what would be your 3 tips for health professionals working with runners when it comes to returning a runner from injury? What are the 3 things that you want them to consider?
So I think the first one is really look at the load management
Yeah.
side of things. I think it's probably the priority for most runners. If they're continuing to do too much and irritating their body, is very, very difficult for you to help settle those symptoms down. It'll just keep irritating them, and you'll find that they're a little bit stuck and not progressing. I think number two would be if you're struggling with that with a runner, like you're suggesting they change things and they're not able to, look at why. So try and
Yeah.
explore, why is it they're choosing to train how they're training? Is there some kind of driver, some kind of belief, sometimes some external pressure that you can work with and problem solve with
Hmm.
them and come at that in the most, empathetical way that you can. So if I give you a quick example, we had a runner who loved running with his daughter.
Hmm.
It was his favorite thing to do. She was home from university for the summer and they were trying to get as many runs in as possible. And I think we can all empathize with that. Like, I know
Hmm.
you're big into family, I'm big into
Hmm.
family, 100% completely recognize why they want to do that. But he was a gentleman in his 50s. His daughter was in her mid 20s, running all the time, able to do quite a lot more than him. And it was just leading to him doing too much.
Hmm.
So we problem solved it together and we said, well, how about we do a bit of a mix? Is there a way you could do some of the running that you can cope with your daughter and then hop on your bike and still
Uh,
be with her for that second half of the run, but you're just doing something that's a little bit easier on your body? So he's problem solving there rather than kind of wagging the finger and saying, well, I've told you to do
yeah.
less. Why aren't you doing less?
Yep.
And then the third thing is, I think, really look to try and progress people's strength work. And
Hmm.
that often is going to mean going more than just body weight. Be prepared to take them beyond that when they're ready.
And lastly, our rapid fire questions. I've got four quick answer questions for you now. So number one, favorite strength exercise for
Or
runners.
I'm going to have to go single leg squat.
Oh, okay, single leg squat, very nice. A pistol squat all the way to the ground, or not?
Ooh, only if they can do it, but probably more to maybe 90 degrees and load it up when they're ready.
It's always impressive, isn't it, when you ask someone to do that, and then all of a sudden they drop down to the ground. All right, okay, that's a tick. That's
Yeah. I can get down, I can't get back up again.
yeah, that's true. Exactly. I just fall on my back. Most underrated rehab tool.
Ooh, communication.
Nice. That's
I know
a
it's a
myth.
bit of a vague
Uh,
one, but it
no,
really is.
no, it's I like that one. A myth you wish would disappear from running.
That there's one way that we should all run.
Okay, nice. That's and best advice for clinicians that wanting to work more with runners.
Go run with them. The
Yeah.
more
Okay.
you're involved in your running community,
Yeah.
even if it's not running, even if it's just helping out at events, talking at running clubs, bringing them into your clinic to give them some sort of free advice sessions.
Hmm.
I think that in-person stuff,
Yeah.
connecting with the runners in the community, they'll get them flooding in if you do that consistently.
And I think that's like as you said, it's that personal nature of what we do, but they see you as a person and they're like, oh, I know Tom now. I've met him before, and it does remove that barrier. Then, isn't it? When they've got problems, then they think straight to you. So I think that's great advice. And my final question: where can our listeners find you, Tom? Where can our runners and our health professionals that haven't heard of you? Where's the best place to track you down? And you don't
So,
have to give your physical address. You don't have to give your home
no,
address,
no,
but
no. No, so my website, which is running-physio.com, is a good place to find out more information. Also, I'm on Twitter and on Instagram. I'm at running.physio on Instagram. So it's good to connect with me there. It's always nice to meet fellow clinicians and runners and things on there.
Yeah, have you actually know how many count of how many blogs you've actually written? Because it would be close to 1,000, you reckon? Because you've been doing it for so long. It is a
Gosh,
fantastic source of
I
information. So,
I would say probably if you were to put together all the blogs, the videos,
mm,
everything, yeah, I would say probably something
uh,
along those levels. And it started out pointing towards runners, but actually over time now it's more focused on the clinicians because I
mm,
realized I could probably help more runners by
mm.
helping the clinicians understand how to treat them really.
Well, you've certainly helped me a lot over the years, and I thank you for that. And it was really a big honor that you've come on. And again, there was no hesitation when I asked you. So I really appreciate your time that you've given today, and hopefully again inspiring another generation of health professionals out there, and to serve and help more runners. So I really appreciate your time today, Tom.
Thank you so much for the invite, Luke. It's been a real pleasure talking to you. I know we have very similar views on things, and I've really
Mm.
enjoyed the content you're putting out there. Your Instagram's a must follow. Yeah, it's really good.
Oh, cheers, Tom. I try and learn from the best in yourself. So appreciate that, and thank you to all our listeners. Look forward to catching you on our future episode. Until next time.